But look, this is a really exciting part of the program where we invite you into a conversation with some key thought leaders in the space, and we are very privileged to have such an amazing lineup of panelists that just come and sit in conversation around these issues from their respective spaces that they occupy. And this yarn about workforce for us is transcending the institutions that employ us and the disciplines that we belong to, and thinking about Indigenous health workforce in a collective kind of way. So I'd like to thank Professor Shaun, who's going to lead our first critical conversation of the program. And we're really looking at the beginning of the journey of a career in health, before and during one's training and entry into the health system. And we ask our panellists, Associate Professor Shannon Springer, Miss Janine Mohamed, Miss Donna Murray and Miss Natasha Lee, to draw from their own experiences and reflect on what they feel are the critical success factors for building an Indigenous health workforce, including supporting the training of Indigenous health professionals, the usefulness of creating Indigenous cohorts, and the enablers for leadership within the health system and beyond. So please make them feel welcome.
Thanks, thanks, Chelsea. As Chelsea mentioned, my name's Shaun. My mother's country is from the Jamara country in the Western Districts of Victoria. I grew up in Ghana country and now live in Melbourne on Wurundjeri country, and acknowledge the welcome that we received this morning. I don't want to go through what I do, and the panellists aren't going to do that either, except to say that as director of the Poach Centre at Melbourne, which has a focus on Indigenous health leadership development and pathways into PhD programs, I'd like to acknowledge our Melbourne Poach Fellows that are here that have done the leadership program. Tamara and Gavin and Brenna, I think, is here still in terms of thinking about her PhD pathways. Whether it's Melbourne or not, that's okay, Brenna. We'll let you go. We're talking a bit about changemakers and building an Indigenous health workforce. We're going to have a very organic conversation, and we're going to invite you to ask some questions as they come as well. But I'm going to hand over to the panellists first, briefly to introduce themselves. Again, not in the bios that are on the programs there, but just to talk a little bit about who they are, their journey into health, and their perspectives on health leadership as well. I'm not sure where we're starting, but maybe with Donna.
Oh, of course. Thanks, Shaun. So I'm a Wiradjuri, Wanneroo woman of New South Wales. So Wiradjuri with family ties to Narrandera and Cowra, and my grandmother's family is Wanneroo from the Singleton area. And I grew up on Wiradjuri country and now working and living in Canberra on Ngunnawal Ngambri lands. And I guess my approach to today is as the CEO of Indigenous Allied Health Australia, and I guess my role in health is really around health administration and influencing health policy. So I'm not a clinician, and I haven't trained as a clinician, but coming from a different perspective today.
Thanks. So my name's Janine Mohamed. I'm an Urunga woman, which means I grew up on Point Pearce Mission in South Australia, and I'm now the CEO of the Congress of Aboriginal Torres Strait Islander Nurses and Midwives, or CATSINaM. I did a degree in nursing in the 90s, so there weren't too many Aboriginal nurses and midwives at my uni, nor was there much content in regards to seeing our women, our nurses, our first nurse being in 1903, we think, being actually exemplified within that course content. So there was very much a vacuum around what Aboriginal nursing and midwifery was, which kind of drove me to where I am today. I also learnt this concept by a Maori nurse, Irahapati Ramsden, who talks about cultural safety as one strategy to actually, I suppose, break down racism or have anti-racism strategies, and to which I still do a lot of work through my role at CATSINaM now. I attended my first CATSINaM conference with Gary over there in 1998 with my baby, who's now 20 years of age, so she's my I suppose, yardstick on my career and my work with CATSINaM. I also worked at the Aboriginal Health Council SA, where I met an amazing Aboriginal nurse who's one of the nursing leaders. That's Mary Buckskin, who's passed away. I had the opportunity to work in Aboriginal health worker training with the likes of Mr. Robert Dan, I believe, is in the room, and I was a WIPO with Neil Wilmot. He'll explain what a WIPO is later, I'm sure. And then proudly went on to work for the National Aboriginal Community Controlled Health Organisations, where I still continued my work in Aboriginal health worker qualifications and cultural safety. And then a man by the name of Dr. Ray Lovett tapped me on the shoulder and thought that I'd be a good CEO for CATSINaM. So I'm an accidental CEO. And I suppose in thinking about my leadership role, I think about what I learnt in dominant culture, which is your position and your power is actually about where you are in the hierarchy. So we get taught that in nursing midwifery, you know, born in the church, raised in the army. But as an Indigenous nurse, my position and my power comes from my people and how I listen to them and how I give back to my people. So a lot of my leaders in my life are people that you wouldn't know of. They're community people, but yeah, that's the way they continue to decolonise me when I work in dominant systems, to remind me that my leadership is to privilege their voices.
So my name's Natasha Lee. I'm a Mwalgal Yidinji Dungari and Kalali descendant. I was born and raised in Brisbane, but I've also spent some childhood in Innisfail and Cairns, where my mother's family's from. Today I'm here to give a perspective as a student, as a Master of Public Health student, externally and part-time. I have 17 years experience working in the Indigenous sort of sector, but not particularly within Indigenous health. What sparked my interest in wanting to pursue a career in health is undertaking a medical anthropology within my anthropology degree, which I got to see the value that social scientists bring to the field of public health, and particularly an understanding how health and well-being is interpreted and understood within different cultural contexts, and also the social and biological influences or factors that influence the incidence of health and disease within communities. I'm proud to be here today on this panel. It's my first, as a panellist, so can't wait to give you my story. Yeah.
My name's Shannon. I'm from Mackay, and I'm currently working at Bond University as the Director for Aboriginal and Torres Strait Islander Health. I'm a GP, and I'm also a graduate from the IAHA program. I'm also a practice owner. So it's been interesting in my leadership trying to influence mainstream general practice around Aboriginal health. I'm also the Vice President of the Australian Indigenous Doctors Association and have lots of opportunities through that in terms of leadership.
Thanks all. We may as well just jump in at the deep end. And I'm sure you've all read Chelsea's Indigenous X article yesterday or the day before, and had the opportunity to listen to Dr. Chris this morning, and perhaps pick up some of your comments first, Janine, about positioning, but also about our personal and professional positioning within and in relation to institutions. There was a critique around aspiration and capacity building, and thinking about that as the jobs that we do. Have you got some comments on how you think about that?
Yeah, sure. So I didn't read it, I'm sorry, Chelsea, wherever you are in the room. So I'll probably answer it just from my own school of thought in terms of being disruptive agents of change. And, you know, I think what we do for our own mob in a personal sense is that absolutely, you know, what I've seen internationally, some of the best programs have been for Māori nurses. We can actually do a Māori nursing program that is completely and utterly tailored for Māori nurses. So, you know, that reinvestment into culture and our ways of knowing, being and doing, and creating those spaces. In terms of how I probably have worked within CATSINaM and creating change really is about getting people on the same page around concepts, so concepts like cultural safety, but also challenging dominant culture, and really, you know, as people that aren't a part of dominant culture or what is deemed as normalism, you know, we can see how we're locked out of so many structures. So for me, it's disrupting what is normal and actually putting culture at the centre of it and Aboriginal ways of knowing, being and doing as a part of normalisation. Indigenous nurses work in a colonial system. It's a colonial apparatus. And so we're asking our people to fit within a system like a square peg in a round hole, if you like. And that's really hard. You can't, do you reset? Do you throw it out? I'm not quite sure of the answer of that, but the first step for us is really getting dominant culture to realise they are a part of that and we are excluded from that, and what can actually happen if we deconstruct that. Does that make sense?
Other comments?
I think if we were listening this morning, and we were talking about racism and the impact of that, but also about aspirations as young people, and that we do have the right to be successful in whatever way that looks for us as successful, and in our career. And I guess I came from government for many years in Australian government, state government, but started my career in an NGO in the Wiradjuri Aboriginal Legal Services. Moved into Indigenous education at university, and then into Indigenous affairs, I'll say for many years. And, looking and expanding into areas like leadership and governance, and how to really drive Indigenous affairs forward by using the strengths of us as people, and that centrality of culture, which really led me to another concept of Indigenous governance in the sense of rebuilding Native nations, and what's behind that as strong First Peoples, and our aspirations of designing our own future. And I think through Indigenous Allied Health Australia, we're really looking at, what are we creating? And we're creating a future of our own design. And I think in the health workforce and the health system, we have to start thinking about what are our aspirations in Indigenous health, and how do we create that vision and future of our own design. And I think that really has to consider that transformational process and innovation, because we do know different ways of doing business and service delivery in a sense of not a standard approach in service delivery, but in an approach that is culturally centred and is a cultural match to the communities in which we're working with.
I think what's also important from a student's perspective when we're looking at aspirations and transitioning into the field of health is that you need to target that quite early in their studies. And I say that because it's quite difficult for me, even though studying part-time and externally, trying to transition into health has been, it's been, as I said, difficult. And one of the reasons why is that the feedback that I'm getting back is that I don't have enough health experience. Even though what I'm bringing to the forefront is a background in anthropology, sociology, ethics and human rights, and political science, it just wasn't enough for me to gain entry into that field. So when we're looking at identifying those aspirations within the university sector for students studying, whether it is public health or whether it is health sciences, it is quite broad. And so if you're bringing in leaders who are in health, and identifying their pathways and opportunities, and also identifying challenges and what they've gone through, because what you're actually building is a resilient cohort of students. So you're prepared to what to encounter within the field of health, not so much, not negatively, but also positively, but just bringing it all together and knowing what to expect. So that will help in terms of the retention of students and also the health workforce. So I think that's quite important from a student's perspective when you're looking at those aspirations as well.
We heard in one of the sessions about deficit discourse as well, which I think is so important. That baggage that we carry with us, what we've been told, and breaking those shackles off, and certainly what non-Indigenous Australia gets told about us, be it, and how that certainly puts a lid on aspirations.
I think from teaching in a medical program, which is highly focused on the biomedical model, it's really difficult to teach into a program which is predominantly about a deficit focus. And I think that's one of the challenges that I have as an Indigenous medical educator, and trying to rebut all the stereotypes that go along with that. it's also difficult to take people within them, the staff and the other people with you on the journey. And we talked about having a philosophical approach to workforce development and taking people with you on the journey and not just focusing on the numbers of the number of people that we recruit and that we retain. It's also about institutional change. But I think we spend a lot of time trying to take people on that journey. And we do it to mitigate resistance, particularly for our students. And that sort of goes, that goes behind the scenes with what we're trying to achieve. However, if we don't have this, and this comes back to the point of cohorts, particularly from something like the IHP program, if you get a cohort of students moving through a particular program, it makes the system has to change. And sometimes it is at the expense of the students, and we try to mitigate that. And I relate it to a little bit like the baby boomers moving through the healthcare system, that the first of the baby boomers are 72 this year, but the impact that that's having on the healthcare system as we get an ageing population, the health system has to adapt and change and respond. And I think it's similar in terms of when we look at large groups of Indigenous students going through programs, that it does affect the system or the institution in which they're learning.
And I think at IAHA we're really trying to build the aspirational leadership sort of development for high school kids, so that they feel safe to dream and aspire to whatever it is that they want to do, but are also equipped and feel very supported in that aspirational journey. And I know, I won't say when I went to school, but a very long time ago, that really didn't exist. And, and I did aspire to go to school to play sport originally, but there was no one ever saying you can be a doctor or you can work in health. That's definitely for sure. And so I think we're really trying to work hard in this aspirational thinking and leadership principle around how do you see yourself? Where do you see yourself into the future, and what's your vision for yourself and your family? And then how do we set goals that are supported to achieve that? And I think I sort of try and do that in my career as well. And I was sort of accidental CEO as well, at the right place at the right time, but I made a conscious decision to challenge myself in a new sector. And health is definitely challenging, and there's always a challenge. But I guess in a leadership way, that's sort of why I'm a CEO, is I actually like the challenge and are willing to put myself in positions to be challenged for others that may not be as strong or resilient for that, and are willing to really challenge people's ideas, like Janine was saying, around racism and cultural safety, and then backing that up using and with our Aboriginal and Torres Strait Islander members, because that's where the expertise and wealth of knowledge is, and I think that's sort of where I'm sharing my skills.
Do you feel confident building the aspiration, if you like, of school kids? Do you feel confident around the career path or the experience that you think they're going to have through university, through nursing school, through medical school, through Masters of Public Health programs? Do you have a confidence in those programs that their experience will be an enriching one?
Well, I want to take a strengths-based approach to that, Shaun, and say that all of the work that everybody's doing here in this room and on the panel, that in 10 more years or in 5 years that there will be a different way of delivering curricula, and that it's embedded and it's compulsory, and those conversations about racism and the system and looking at reforming into the future. So we're designing, co-creating or designing our futures. But I think there's still a long way to go. But that's not to say that there's a much more structured support, particularly around coming from our national, like IAHA, CATSINaM, IAHA, and NATSIWA, in that we're really looking at what is the workforce support needed, what is this long-term structural way we need to think about working with education providers, training providers at the vet sector level because of the pathways, looking at building what are the pathways that our young people need and want to come into the health workforce. Because we sometimes forget too that the support workforce is critical to health. So allied health assistants, rehabilitation assistants, enrolled nurses, there's a whole range of assistant workforce that we need to embed into our community models of care and support that. And from there, pathways grow, and we're finding, particularly with our allied health members, they're coming in, well, they're already qualified Aboriginal health worker, practitioners, or even nurses, wanting something different in allied health, but then we're doing such a great job that medicine and IAHA then take them on as graduates and move them into medicine very successfully. And in a sense, that's a real achievement, and I think that's contributing to the growth of the medical workforce. But what it is then for those aspiring in allied health, we're really still paddling all the time to keep up in building the allied health workforce. But you know, I think if we put in really good structures around pathways, it's about the health workforce, not particular professions, and we have multiple ways and entries into that, but supporting an education process, and then what does that mean for success? Transitioning into the workforce is usually the hardest part. Yeah.
I think sorry, do you want to go?
I was just going to pick up on the actual the workforce and workforce ready. We're doing some work through the Australian Indigenous Doctors Association at the moment with looking at our doctors that have gone through their medical training, they've graduated from medicine, gone through their hospital training. They've entered onto their specialty training college pathway, and then for whatever reason have not been able to finish, whether it be through exam, whether it be through social factors, cultural factors, haven't been able to meet the requirements of the college. And then these doctors are no longer on the training pathway, and therefore can only practice in areas of need, often in Aboriginal medical services where they wanted to work anyway, but haven't been able to obtain their fellowship. So these, there's a group of people out there that are practicing very difficult medicine and are not supported. And, the question from our colleges in terms of the other end of the training pathway is that, are we providing adequate training to develop doctors in this case for community need? And people are falling over due to multiple choice questions and, these other sorts of facets. And there is a belief that they are competent and they've been working in their community for a long period of time, but they're not getting their fellowship. So we're putting all of this work in by recruiting students, which is a small pool, getting them through medical school, getting them through the difficult hospital sector, which is sometimes terrible to go through, then getting through college, and then falling over at the last hurdle. So looking at the whole pipeline, I think there's different needs and different aspects that we need to respond to, and institutional buy-in, and looking at the way we train people across the whole spectrum is really important.
I think that also just within the university sector, some of the students are not too sure what they want to, or the areas that they want to get into when they finish their degree. And for me, in terms of career pathway, it's just been a little bit difficult because you've got the cadetships and the internships and work experience, and more often than not, they're supplied or offered to students that are studying full-time internally. And as I said, I'm external, part-time. And I'm lucky because I live in Brisbane and the university that I attend is in Brisbane. But one of the reasons why I did choose to study at UQ is because it offered the specialisations that I was interested in, and it did say it enabled you to transition into the field of health. So that career pathway for me is, like I said, previously it has been a little bit difficult. So if we open that up to accommodate for students who studying internally, externally, part-time, full-time, that'd be really great for that opportunity, and you can upskill that way. But there is, at the end of the degree, like Shannon was sort of talking about, students sort of falling off. you have to bridge that gap between university and getting a job. And that's the ultimate goal, is like getting a job. Where am I going to go? So there needs to be something that's coordinated, that's advertised, and that matches the skills that we have with students that are coming out of university as well.
For me, I suppose you have to have faith that you're actually putting people into, universities and that they're going to have a good outcome, or else you wouldn't get up in the morning. And sometimes it is hard to get up in the morning. But I think the remedies for our future are still in our past, and all of the answers are still there and remain unfunded. One of the seminal reports for CATSINaM is getting them and keeping them. Those recommendations still remain unimplemented and unfunded in many ways. And I suppose the same, big headliner issues still exist, which is racism. And then also now what we see is a lack of cohorts of students going into university systems. So I think there's an issue and also there's an answer as well. I certainly went through with a group of Aboriginal people, and there was a real strength in that connectedness and that cultural hub that I had in my student support unit. I suppose the good news is that I've got 5 kids. 4 of them are all at uni, and I was the first one to go to uni, and they really felt that they had choice, that they could be anything. When I was growing up, you didn't have much choice other than to be a domestic, or if you're a young lad on the mission, you could be an AFL footballer. So I think, role modelling and people actually from the community controlled health services, we see our kids being exposed to health professionals and seeing themselves in those roles. There's some really great programs around, so universities are doing awesome stuff. Roy and I know we'll talk later about Griffith University, but that's probably one of the best programs going around, which is the Hands Up program, where they bring families into the university and they get to see where their kids are going to go to uni, and there's a real connectedness with the local community with that uni. We've developed a Leaders in Indigenous Nursing and Midwifery Education Network, so the content of Aboriginal health, culture and history and cultural safety is at a quality level. There is definitely professional paralysis of people wanting to teach that, and to be honest with you, I don't blame many lecturers. It is really hard to teach. As Shannon was saying before, there is resistance, but what's that I was saying? Resistance is useless. They've got to do it these days. But, it's not a sexy subject, for the universities to uptake. And, these days what we're finding, Donna, correct me, but there's a real lack of scholarships out there for our kids. Tutoring doesn't happen the same way tutoring happened in uni when I was at uni. You had someone assigned to you that was actually your navigator through the system, not just someone that helped you in your subjects. Chelsea mentioned this morning the Aboriginal Health Worker Journal. We don't have that anymore. We were, Neil and I were a part of the WIPO network and the Aboriginal Torres Strait Islander Health Workforce Working Group. That's missing as well. So there's lots of, ships in the night they've just gone. They're not there anymore. In terms of workforce ready, I'll probably just say a couple of things that we're doing well within our Aboriginal and Torres Strait Islander Health Workforce Leadership area, and that's the National Safety and Quality Commission now have named cultural safety as a requirement for health service standards. So health services have to demonstrate that they're culturally safe come January next year. So, that gives me a bit of hope, Shaun. But now people have to say they have anti-racism policies, but what I'm going to be really interested in is if they use them. Yeah. So you can have those policies, but are people actually going to be held to account if they're being racist? Legislation is potentially happening in health practitioner legislation. That's out, it just closed the other day actually, so hopefully we'll get cultural safety named in health practitioner legislation for the first time in this country, although it's already happening in New Zealand and in Canada. So that gives me confidence. And cadetships are really, really important. New South Wales Health do a great midwifery program in cadetships, so that helps transition to practice and building relationships. But I heard someone say it this morning, part of the problem with transitioning people into the workforce is actual jobs. Yeah. So people are crying out for an Aboriginal Torres Strait Islander nursing midwifery workforce, but 15% of our members can't get full-time work, and many of them are part-time working. So when we see these counts from government that we have a system where we have Aboriginal people employed, they're not full-time equivalent. They're part-time people and they're only on contracts. So I think there's work to do.
That's very common in allied health. And a lot of our members are looking at medicine and other pathways, because when they graduate in their fantastic course, they find it very difficult to find a full-time permanent position in an allied health profession within Aboriginal and Torres Strait Islander communities. And so we can build a workforce and we can get them out, but if we don't have workforce models and really good planning to meet the need of our communities, you know, what are we doing? We're losing that workforce either to mainstream, or we're losing them to out of the health workforce into other areas and other sectors. So there's some critical issues there. For
and I don't think the medical sector's got that right either in terms of the overall workforce, because, you know, we're producing more doctors now than, you know, ever before. We're pumping them out, you know, and when we get to about 4 doctors per 1,000, you know, it's probably going to be a public health risk. But I think the point is that we're producing so many doctors, and there's going to be this bottleneck in the hospital sector to get them trained and then get them out into community and doing what they want to do. So,
and I think that's another issue, clinical placement.
Yeah, absolutely.
You know, it would be wonderful to have supported clinical placement in Aboriginal community-controlled health services. Certainly, I know many of our members want to work in those areas or get their clinical placement in those fields,
that's
but
actually
can't.
funded and supported appropriately. Yeah,
across all professions, across the whole workforce, really.
Yeah, all professions.
I'm wondering if we changed our language a bit, we would drive our machines that develop our workforce, the universities and the hospitals, to focus on slightly different things. So we heard a bit this morning of focus on population parity. I get why that's a target, but I think it loses conversations around quality. Often it's also a conversation around admissions, but I wonder what it would be like and how it would change the work that we did if instead of focusing on admissions, we focus much more on graduations. What is the target to graduate X number of health professionals rather than admitting them? And how does that change the kind of things that happen while people are learning to be health professionals? Have you got any comments on that?
Well, I agree. I think we don't spend enough discussion on completions. And I know in our organisation, Indigenous Allied Health Australia, we're really trying to focus on what is it that students need to succeed, and what is it that the gap, what's the value add that our organisation can provide, that universities making them accountable for what they're supposed to do, making the system accountable. But I guess for us, the students are really looking, their critical success factors were that they need to feel culturally safe within their institution, to be able to be heard and to be able to be who they are without fear of consequences, that they needed mentoring. And a lot of the mentoring was really focused around profession, but also around that cultural mentoring and around how do they approach feeling unsafe, who you know, what's the process, how being together in a cohort, in a network that Indigenous Allied Health provides made them feel much more confident and really help drive them in the direction to achieve. And some of our statistics has shown that if you're a current student at a university in Allied Health and you're a member of Indigenous Allied Health Australia engaged in the student and engagement strategy that we have, you're 90% completing in your course. And there's a couple of fabulous graduates that were students with IAHA here that can attest to that, and are moving into leadership, are really getting involved in the sector and about transformation, you know, and looking at it from a different lens, but confident to use not just their clinical lens, but their cultural lens and expertise in their positions. And so that's something that we're really working at.
I think we heard it earlier today. Again, one of the sessions was about hope and being valued, was really important for completion rates. In terms of measuring that, we don't have good measurement, and I think Indigenous Allied Health Australia certainly has that issue. We know that we're 1% of the Aboriginal Torres Strait, 1% of the overall nursing and midwifery workforce. To actually get that up to at least population parity, so that's 3%, not talking about burden of disease or need, that takes a targeted approach of a university wanting to value their outputs and measuring that as well. Some of the things that we've talked to universities about aren't dissimilar to Donna. It's mentoring, tutoring, connectedness. Culture is seen as an asset. Anti-racist policies, Aboriginal academics. Royanne, again, will probably talk a bit about her PhD and some of the steps that institutions have to take to actually get those completion rates happening. But we know our completion rate is only 30%. So, out of 100 Indigenous peoples going into doing nursing, only 30% will complete compared to 60% in non-Indigenous. So in terms of the opportunity, it's quite amazing. So it's that exists. So we did an economic analysis, and some of the things that we talked about in that was completion rates actually add to the Australian economy. So that really spoke to politicians. You get health literacy in the home, you get economic participation, and you get mentoring and role modelling, all of those, unintended consequences of graduating an Aboriginal nurse, let alone the impact that they will have for the Aboriginal Torres Strait Islander clients that they have in hospitals.
I just wanted to add on, sorry, with your point, Janine, just with mentorship. We do have mentorships within the university, but it's informal, it's not structured. And so I had to go out of my way in order to, not so much collaborate, but find out who the current MPH students are, graduates as well, and getting their advice and preparing me for what's yet to come in the actual degree. So if we can have that sort of in place with universities, that'd be great, a structured mentorship program. A feeling valued. As an external student, I'm quite isolated, and how do I, sort of put it out there that I guess for the university and the workforce, enabling me to feel that value. I've got a lot to offer, I've got a lot to bring, but there have been occasions where I've sort of, should I continue down this path? I'm not too sure whether I should do that. But, one of the things that I was sort of raised with is understanding that, you've got to help your fellow mob, and the strength that it brings to the culture and in your family and the community itself. So that's always in the back of my mind. But, we spoke about it this morning, about the value, feeling value. It's really important, really, really important.
I think medical schools have come a long way in this area in terms of recruitment and retention, and I know we're streaming live, so that one's for you.
Was it Bond?
Yeah.
Not James Bond.
Yeah. But in terms of recruitment and graduation rates, I think Chris mentioned this morning that at the moment the doctors are less than 0.5% of the overall working population. And if we continue the recruitment and graduation process as we are, we'll actually go backwards. So what we're talking about is actually lifting what we're doing now, and thinking about different ways of doing that.
I've got one more question for the panel, then we've got about 10 minutes where we can take questions from the floor if there are questions. The focus of the discussion has been around, as we've asked to be, building an Indigenous health workforce. And all of our panellists either currently are or have sit in leadership positions in Indigenous-related organisations. And I'm wondering, this is a question without notice, where are we most effective? Are we most effective as Deputy President of Indigenous Doctors Association, or are we more able to influence change as Vice President of the AMA, and similarly for nursing and allied health and land councils and so on? Where, if we want to change the health workforce and where it's being built from, do you think we might be more effective? Where we currently are, or in different kind of positions?
I think I've gone full circle on this, having worked through the working in the AMS and then coming through that and then working in trying to teach medical students and then trying to develop a recruitment process and a retention model and then working with colleges. I think we can spend a lot of time taking the system on a journey, and I think that takes a part of you away. And you get burnt out and you get fatigued and you're continually challenged. Why we have to do this, and in terms of bang for buck, I think, well, why am I here as well? Instead of focusing on putting my energy into our own people rather than the non-Indigenous population. So I'm sort of going full circle and looking back at the IHP program as a great model to say, maybe we need our own institutions and we need our own colleges and we need our own spaces to not only develop big numbers and big cohorts to move through the healthcare system, but also learn in models and learn in ways of Aboriginal being and knowing it, instead of trying to take this deficit model of learning health and then trying to put some sort of spin on it, which people unlearn through their careers anyway. So that might sound a bit negative, but I'm just thinking, I think I don't know whether we got the system right.
I think for me it's a really personal question. Obviously at the beginning I spoke about many different jobs that I've done. Most of it has been with a mandate, with people that are a part of a membership. So I think that's where myself, I'm most comfortable. But that's not to say that I don't seek out and feel most comfortable with other Aboriginal people working in government, politics, within boards, etc. I absolutely applaud my Indigenous brothers and sisters who work in bureaucracy, trying to change the machinery of government. And I know when I have another Aboriginal person in the room with me at various meetings that we're coming usually from the same page. So I think we need to be everywhere. But I've had to come, like Shannon said, full circle and do all of those jobs to be able to do the magnificent job that I've been given with CATSINaM. And so I think that's where I'm most comfortable, and what I've learned is that, yes, I get to do all of those other things, but as I said earlier, I'm speaking on behalf of a membership and privileging those people's voices. But the most effective job that I think I have is working with young Aboriginal nurses and midwives, really revering and valuing their strength in their culture and their identity in that, because if they're not strong in culture and in their identity, they won't be as good a nurse or midwife, because when they get into that system and someone assaults that identity and they're not strong in that, that's when they begin to get stressed, and that self-care needs to come into place. So I hope that makes sense. But I think my biggest job, where I'm most effective, is raising 5 children. Yeah, that's my big job.
Mine's 6, but yeah, we're all adults now, so my job's done.
Get one up me.
Just quickly leading from that is that I think in my position, I think we need to be everywhere, but having been in government for a very long time, I think the reason I left was that I was tired and I was burnt out about trying to change the institution within. And, I don't think that's really going to happen anytime in the near future. But coming into an Aboriginal controlled organisation, and particularly this peak body, who is still only 9 years old, 10 years next year, has been absolutely a privilege in driving our own agenda and setting what does allied health look like for Aboriginal and Torres Strait Islander people? What should this workforce look like for Aboriginal and Torres Strait Islander people, led by Aboriginal people, for Aboriginal people, with Aboriginal people? And I think we can get a lot more done in our own organisations with really solid Indigenous leadership at all levels, and I know Chelsea said today, this is in mainstream, it's a hierarchical. In our system, leadership is vertical. Everybody here is in a leadership position or role that they could take on change and reform. It's identifying what and how, but I guess driving our own future is also our responsibility as a national body for our members, is ensuring that we're building their capability, confidence and capacity to then go and transform their own profession and or workplace with us fully in support and having their back, you know, so that they know they can come back and feel supported, talk those challenges through, look at active strategies with others that have been there. And I think that in the allied health space with our members, particularly in some professions like OT and speech pathology and psychology, definitely, has had real change. That's us coming from a policy and a curriculum and embedding standards around cultural safety in the profession, but the members then challenging the profession ideas about the workforce has been really powerful. So that's where I think, yeah.
And I just wanted to reiterate what Janine and Donna had mentioned in terms of having representations of Indigenous people in all facets of, you know, of not only government, but just, you know, whether it is in policy and IT, engineering, everywhere. And then having a collaborative, a collective approach and making that change to address not only, you know, health disparities, but just address the direction where Indigenous issues, you know, are going in the future. And we do focus a little bit on the negative. And I hope that today, with what I've mentioned, it wasn't so negative at all. But I just wanted to put some light in terms of, you know, the challenges that I've experienced. But I think, yeah, it is important that we have representations at all levels and working together for that collaborative approach.
Thank you. Just a few minutes for any burning questions from the floor, and I think there's a roving mic somewhere. So if you've got a question, can you make yourself known? Surprisingly, Chelsea has a question.
Where?
Deb?
Oh.
We'll go to Deb, and then we'll go to Chelsea, and then we'll close up because we're nearly right on time. No.
Thanks. Deb Askew from the University of Queensland and Denala Indigenous Health Service. Janine, I was gobsmacked at that statistic you cited of only 30% of the Aboriginal and Torres Strait Islander nurse students graduating. Can you talk a little bit more about that, please? And what can be done to actually support those students to get through to the end of their training?
I think these are Roy Ann's stats. Is she in the room still?
She was.
Yeah, their sister. So it actually had a little blip, hey, where it went up at one stage. And we kind of think that might have been the Puggy Hunter Scholarship where it went up. So that's a somewhat of an answer, that scholarships are extremely important. Look, I probably am only going to repeat myself in terms of what we need to do. It's cohorts, mentoring, student support units. I think some of the other things are around the institution itself, having relationships with Aboriginal Torres Strait Islander peoples, nurses seeing themselves in the curricula. So I talk a lot about historical truth-telling and historical acceptance, and that means that, for example, in the midwifery course, you have to acknowledge that birthing on country happened for 60,000 years and we had midwives here before the first fleet. And that's not necessarily the experience of all midwives going through midwifery courses at the moment. You know, our academic lecturers being Aboriginal Torres Strait Islander peoples, having culturally safe environments. Yeah, and of course, I think I might have mentioned tutoring already. Yeah. So those are just a couple of laundry list things, but it's leadership. You know, first and foremost, you've actually got to value and want Aboriginal Torres Strait Islander students in your faculty, and that comes from the highest levels. So if we look around at our very institutions, how many Aboriginal people are on the boards of universities? So, and that's a bit of self-reflection, critical self-reflection that the university has to do for itself. And I think I've heard one university say to me, we don't have any Aboriginal students, so why do we need, you know, that content, those supports? And that's why they don't have Aboriginal students. Yeah.
Hello.
Those drivers of success were also echoed in the research that Tess and Chris presented around building the Aboriginal health researcher workforce earlier today as well. Same kind of stuff. Last question.
So I think the national average for completion is about 47% for Indigenous students in health.
I'm sorry, so my quick question, I think probably perhaps it's directed at Shannon, having gone through a cohort and a Indigenous focused undergrad degree, and then watching the student journey now as an educator. Back in the day, the Indigenous specific course was seen as like a Mickey Mouse course or a supported learning environment, that because we couldn't just make it like the rest of them. I'm just interested in your reflections about the Indigenous specific course for Indigenous students, and the imaginings of those kinds of places as being not as the places where those who aren't smart enough have to go, in terms of how it shaped your own journey.
Well, I think going through that program at a critical time in my life was really important as well. So that model of having a cohort of Aboriginal and Torres Strait Islander people coming from multiple places, and picking up on what Cindy was talking about this morning in terms of problem based, and then the experience being in the room was really valuable, and I think that helped consolidate my learning and my understanding, and also help develop my passion in health and grounded my identity. And then that was really important in transitioning into medicine, where you're really on your own, and there's some patchy education throughout, and you're left as a student doing a lot of the teaching in the corridors, and that's the same experience today, even with the students that I teach, because we just don't get that breadth of training and understanding. So on reflection of that program, that program put me on a pathway and changed my life. So, and I definitely wouldn't be here if it wasn't for that program.
Thanks for your question, Chelsea. We're out of time, so can I ask any final comments, burning comments from the panelists? Janine, you've been writing something down?
I was actually just writing something about what Shannon was saying, and the question from Chelsea in it. And I think that's the discourse, isn't it? That deficit approach of why does Aboriginal people need scholarships? Why do we need to learn about Aboriginal people? And really, if people understood the exclusion that we experienced, and what equity actually is, giving people what they need, not assuming we all come from the same start in life, then those sorts of throwaway comments, which are really quite damaging and lead us to believe that we're dumb, would actually wouldn't even be asked. And I suppose the opposite of that is being strengths-based, and those comments that we've survived for 60,000 years, and aren't we an amazing race that so many people could learn from. So that was just my thinking when Shannon was young.
And I think one challenge for us, I guess, and for universities is the flexibility in course delivery in health. And so I'm all for Indigenous cohorts, and there's the health science mental health course that is blocked for Aboriginal and Torres Strait Islander people. But again, Chelsea, it's seen as a Mickey Mouse course, and it's not. It's a mainstream degree with a cohort of Aboriginal and Torres Strait Islander people. But the inflexibility in allied health is a real issue to the growth of the workforce. So, there's a challenge out to universities about how can we do this better? How can we do it in cohorts where people feel safe? And the statistics can show that you get much better outcomes in the end from doing that, and be brave and innovative in this space.
And offering those flexible options allows students to flourish. And also, I guess, it works in collaboration with the higher education system, Indigenous community, but being able to do that would be great, would be fantastic. Yeah.
Okay, on that encouraging note, can you join me in thanking the fantastic panel?